Welcome to the Future of Medicine podcast, presented by Predictiv, the first DNA-based digital twin to predict and prevent over 22,000 diseases.
Hi, everyone, and welcome to the Future of Medicine podcast. In this episode, we will explore how science and technology and the people in it are shaping the practice of medicine, from genomics to precision medicine, AI, and to in-home diagnosis and treatment. Our guests will share their vision and how they contribute to the future. Today, I have the pleasure to have with me Dr. Stephen Winiarski to talk to us about cholesterol. Dr. Winiarski is a family medicine physician and a specialist in treating cholesterol-related diseases. He recently combined his two passions and started the first telemedicine lipidology practice called Cholesterol Doctors. He focuses on the treatment of challenging cholesterol disorders, statin intolerance, and performing advanced risk assessments using state-of-the-art testing. His special interest is leveraging innovative tools and technologies to optimize health and longevity, especially for those beyond middle age. Dr. Winiarski, welcome to the Future of Medicine podcast.
Thanks for inviting me.
Could you tell us a bit more about your background and how you melded your two passions?
Sure. I started as traditional family practitioner, and I did, I would say, full scope family practice after residency for about 9 years or so. And during those 9 years, I became a little bit disheartened with the lack of innovation in what I was doing. I really wasn't evolving my practice. I wasn't evolving much of what I was doing for my patients. So I was really looking for taking the next step. I mean, if we were to look back in history, I mean, medicine really, up until recently, hasn't changed that much, generally speaking. I mean, we're still delivering the same type of medicine. So the patient's coming to the doctor is examining them on the table, giving them treatment, a diagnosis, and sending them home. And recently we've seen this technological revolution. We're talking about the 90s, the early 2000s, the internet, and these tools have been available for us, but medicine has been slow to adopt them until recently. So now, as we've all experienced with COVID, right? The acceptance of telemedicine has grown exponentially. Before, we were seeing a gradual growth and acceptance, and now we were almost forced to accept telemedicine, and we saw that telemedicine was a viable way of bringing care to people, right? So that's one example of the evolution of medicine. The other example is that we have all these tools available to us that we can now leverage in order to benefit the patient in many different ways, right? I think we've come to a part of medicine where we almost have more tools than we know what to do with, and we're trying to figure out exactly how to use those tools for the greatest benefit of the patient. So that's where I was. I continued to practice family medicine. I got interested in lipidology, which is the science of cholesterol disorders, mostly because heart disease is the #1 cause of death worldwide. And I was wondering, how can I affect people's health in the largest way? And I thought that by minimizing the risk of heart disease, this would give the greatest benefit to people. And then gradually, over time, what I noticed is that, heart disease is not necessarily just heart attacks, it's not stroke, but it's a gradual evolution of a disease that takes decades to manifest. And when we see heart attack, when we see stroke, we're just seeing the very latest stages of the disease process, but the disease really has been going on for decades. So that has been my focus, really, is to, number one, help people realize that this is an avoidable disease, and number two, make them realize that the heart attack or stroke is really the end portion of the disease, and it really must be, the treatments must be started earlier.
Yeah, thank you for that. And really what a fascinating journey, starting from, realizations of the needs of your patients and how to better achieve better outcomes for them, as well as looking at the resources that are available now and, that are still are really the advancements in caring for these patients. I just want to kind of take us back a little bit as to, for our general audience here, just give us a little bit of what is cholesterol, and you've given us, that this affects a wide range of people.
Right.
And a lot of people will get this diagnosis, high cholesterol, at some point in their life, maybe sooner than later. We're seeing in the recent years. When we're talking about good cholesterol, bad cholesterol, how do we navigate this as patients?
Yeah, I mean, I think most of us have heard about cholesterol, growing up, right? Cholesterol is bad for you, but really this is a misinterpretation or maybe a misunderstanding of what cholesterol is. Cholesterol is a sterol, it's a fat that we have in our bodies, and that we all use. All our cells use it. All our cells need it to help create our cell membranes, to create hormones, right? And when we're talking about high cholesterol, we're specifically talking about an elevation of the amount of cholesterol within our bloodstream, okay? So what we're measuring when we take our blood is that cholesterol which is within the bloodstream, not which is within the whole body. And it really doesn't represent the amount of cholesterol in our body, right? So when we do have high cholesterol, we're talking about an inability of the body, for several reasons, to absorb that cholesterol. And you can almost equate it to diabetes, right? So when we're measuring glucose in the blood for diabetes, it's an overabundance of that chemical, the glucose, within the bloodstream, right? And the body's unable to take it in, and that's what's causing the issue. The same thing with hypercholesterolemia. For several reasons that we can get into, there is an overabundance of the cholesterol within the bloodstream, and then that causes issues, right? And this places you at risk for cardiovascular disease. Specifically, those cholesterol particles irritate the endothelium, can penetrate the endothelium, and then lead to dysfunction of the endothelium, and then further on, the creation of atherosclerotic plaques.
Okay, yeah, I think that's a great just overview, and that comparison to diabetes, I think, just kind of brings it home. Looking at sugar and fats for myself and for our audience. So, like what you mentioned earlier, it kind of goes unnoticed and falls under the radar because of the lack of symptoms early on, and it really is a buildup over the years. From your practice, could you just tell us a little bit about how one could be more aware and in knowing if they do have it, they don't have it? What should we be looking for?
Right. So again, this is very similar to diabetes, right? We get screened for diabetes early on, and what we do is we check our blood to see if there's an increase in the blood sugar. Really, nowadays, we're a little bit better at it, right? And what we're looking at are the precursors that lead to the increase in glucose. The same thing I would say we do with atherosclerosis or heart disease, right? We're not waiting for people to have a heart attack. We're not waiting for them to have peripheral artery disease, which is a complication of elevated cholesterol. What we want to do is look to see what are the environmental factors within the body that are predisposing us to developing this disease that will be starts when we're in our 20s or 30s, and then takes 30, 40, 50 years to develop until it manifests as heart attack, stroke, or complications thereof, right? So it's almost like investing in your retirement account, okay? So we have to make the efforts now to so that in the future that we'll have a nest egg, right? And then we can retire. So in the example of cholesterol, what we do now is we invest in diet, we invest in exercise, supplements, medication, whatever we need, right, to decrease the level of cholesterol, to decrease our risk of cardiovascular disease, so we can enjoy what we want to enjoy when we're 70, 80, 90, being with our grandkids, exercising, traveling, and not having to worry about a lot of the chronic diseases that we associate with old age.
Got it. Got it. And so in terms of right now, if I were to say go to a clinic, when would be a good time to start the screening and looking at preventative guidelines?
So I think, the screening should start very, very early. I mean, when we're in our 20s, we don't think about it, right? And this is when we're should start looking into this. Why? Well, for two reasons. One, the manifestation of atherosclerotic disease is a product of the amount of cholesterol you have, the level of cholesterol, and the length of time you've been at that level. All right. So the body can tolerate high levels of cholesterol for a short amount of time, right? But if, for example, if you have some genetic mutation that predisposes you to have high cholesterol, you have a family history of high cholesterol, you've adopted a diet that increases your cholesterol, and it started and you notice in your 20s that you have high cholesterol. If you do nothing about it, when you're 40, you've had 20 years of elevated cholesterol and the exposure to that cholesterol and what that can do to the endothelium, right? So if you can get it beforehand, right, do a screening test, very simple, very inexpensive, basic lipid profile, right? Probably runs $20. Anyone can get it done and see where you are. If indeed your cholesterol is borderline or elevated, now's the time to make those changes that you need to make, whether it's dietary, lifestyle, or in some cases, if you have a family history of elevated cholesterol and heart disease, to be more aggressive.
Okay. Talk to me about the advancements in testing, screening, and in this case.
Sure. So, I usually like to think that medicine, and especially lipidology, is like peeling an onion, right? Every time you think you know something, you peel the layer and there's another layer and it goes down deep. And so I think it's the same thing. We learn more and more every year about heart disease, about the risk for heart disease. So I would say earlier on, we would do the lipid profile, which is just a cholesterol, an LDL, an HDL, and we would be pretty happy. Right. And now what we're realizing is that there are better tools, right? So when we're talking about cholesterol, we're talking about the sterol, right? And what's really important is how that sterol is transported within the body. Okay. So if the sterols are transported within something that we call lipoproteins, are not water soluble, all right? And what seems to be more important than the amount of cholesterol you have is how many of those transporters you have, right? So now we can measure the number of those transporters. So that gives us more detail about the risk, all right? So if you look at a cholesterol level that maybe is not that elevated or is borderline, but then you see a number of transporters, but whether that be LDL particle number or ApoB that is elevated, that can give you some insight into maybe risk that's been hidden, all right? And then we can go down to the next level, right? So there are independent risk factors for heart disease, right? That could be lipoprotein(a), which is an inherited lipoprotein level, right? That can put you at risk independent of your lipid level, right? So now the National Lipid Association is recommending that everyone get their lipoprotein(a) measured at least once in their lives, all right? And that's going to determine risk beyond what you could determine with the just basic lipid profile.
Okay. And I heard about this. There's at-home cholesterol testing.
Yep.
Could you tell us a little bit more about that?
Okay, so this is something that's developing. Lots of labs are developing, and the challenge is being able to do testing that's very accurate.
Mm-hmm.
And now as technology has advanced, we're getting to a point where some of the challenges in measuring an accurate amount of cholesterol have gone away or have been resolved. Right now, whenever I talk about making changes, human behavior, I talk about suggestions for change and then feedback. I think we all need that. All right. And then I think we all recognize we have a watch. It tells us how many steps we're doing, right? It tells us how we're sleeping. All right. So if somebody tells you, hey, you need more exercise, you get immediate feedback that day. I've done my steps for the day. All right. So that helps in behavioral change. What's very difficult in measuring cholesterol or maybe something similar is that you'll go to your doctor. He'll tell you have high cholesterol. He'll make some suggestions for dietary or lifestyle changes. And then you may not get that cholesterol checked again for 6 months or a year. So it's very difficult to maintain those behaviors without that feedback. Now, if you can do the testing at home, it's simple, it's inexpensive. Maybe you could do it every month, right? And 5 drops of blood, send it to the lab and get your results back. You can get feedback very quickly, right? And say, hey, I made these dietary changes. It took a lot of effort for me to do that. I started exercising. What is the return on my investments, right? And you see that whether there is or not, right? And if there is, you continue those changes. And if not, that gives you information too. It tells you those efforts have been spent in something that's not giving me benefit. Maybe I can do something else, right? So that you're not spending 6 months or a year doing something that's not going to benefit you.
Right. So it sounds more like a quick feedback, seeing and testing,
Yep.
and also really engaging the patient in the care and bringing a lot of the clinical testing at home.
Right.
That's fascinating. This is the first I've actually heard of this.
Mm-hmm.
So it's great to learn about that. Is that now available for consumers or?
So it's the testing that I use is through Boston Heart Diagnostics. It's a new program that they have, and we're trialing it out. And it's really, it's new. It's within the last couple of months, and I've done it myself, and I've gotten great results with it. So I'm eager, to use it on my patients so that they don't have to go to the lab. Not only is it inconvenient, now people are worried about COVID. So I think this comes out at the perfect time.
Okay. Yeah, I would actually love to hear more about that and also provide that information to our customers if you'd like to send us some
Yeah, I'd be happy to do so.
Yeah, that's great to hear about that.
Yeah.
And so now that we're getting back into screening and the advancements that are happening right now, I'd like to talk a little bit more about maybe the treatment and management.
Yeah.
So a lot of people, as you know, statins, the most common drug that's prescribed, and it's dear to my heart because my mom actually had an adverse reaction to statin. And so how do you manage that people, who may respond well to statin, people who are not responding well to statin, people who can't take statin?
Yeah. So I think it's good for people to realize, or maybe reframe the question. All right. So the question should be, I am at high risk for cardiovascular disease. I want to lower my risk. This is what I've been doing to lower my risk. All right. Here are the options, right? Statin, I would say, is an option. It's not the only option, right? I think I always start with diet and exercise, lifestyle changes, right? I think most doctors would do that. Don't smoke, optimize your glucose, right? Optimize your weight, right? And then, we can start looking at optimizing your cholesterol. So you can do that by, some people are very sensitive to saturated fats, right? So I ask them to decrease saturated fats. And this is where the testing comes in. Not everyone's sensitive. I would say the majority of people are. So I tell them, hey, go on a low saturated fat diet, test yourself in a month. You can do a easy test at home, and you can get feedback, right? If your efforts prove fruitful, then you know that that you can continue. All right. So what going on, say you've done everything, your cholesterol is still high, maybe you have a genetic predisposition to having high cholesterol. We're fortunate in that there are other options besides statins. You mentioned that your mother was not statin tolerant, right? So you have medications like ezetimibe that can decrease cholesterol, right? And different mechanism. You have a new medication, bempedoic acid, right? Also taken as a pill. You have PCSK9 inhibitors, which are a very new medication. And I think we've all heard of monoclonal antibodies. So this is the monoclonal antibodies to a part of the cell that allows the cell to take up more cholesterol, right? And this is given as a shot, right? It's given, and it's interesting, it's a little mechanism, you put it on your arm and it automatically infuses that medication, all right? And coming down the line are medications that you inject once every 6 months that keep your cholesterol down. And then we're talking about very soon in the future, using CRISPR technology to make permanent changes. That research now is already being done in monkeys, and it showed great effects. So we can see maybe in the next 10 years that if you do have a genetic predisposition to having high cholesterol, you're not taking medication to reduce that cholesterol. You're getting a treatment to repair the damage that was done or the mutation that you have. So it's really an exciting time for lipidology. There are lots of options to reduce that risk for cardiovascular disease.
Yeah, that sounds amazing. And also just having different options now and hearing about them, I think is good to know that, it's not just one statin is the answer. Yeah. So thank you for sharing that. And as you've mentioned, the CRISPR technology and all of these advancements, both in screening, testing, and management. I'm going to change a little bit gears here and just kind of get your thoughts on where do you envision the future of healthcare and medicine, say in like 5, 10, and even 20 years?
Yeah, I think it's similar to what I was mentioning. A lot of what we're doing now is putting chemicals into the body to affect a change, right? So you mentioned statins, right? Statins inhibit an enzyme that allows the cell to create cholesterol and forces it to take it up from the bloodstream, all right? So you can imagine then the future, we won't even have to worry about medications at all because we're going to make those changes directly to the cell. All right. We're not going to have to worry about intolerance to medications. We're not going to have to worry about metabolism, right? And if you think about it now, there's so many variables that go into how a medication taken by mouth works within the body, how it's absorbed through the gut, how it's metabolized by the liver, right? How it affects the particular thing it has to affect within the cell. So we're going through several stages, and each one of those different variables could be unique in a person. Now, you can imagine that if we go to the next level with genetics, use CRISPR technology, for example, we're able to say, hey, we want to make this tiny change, and you give the injection, you make the change. You don't have to worry about any of the variables that we have talked about because there's not absorption through the GI tract. There's not metabolism through the liver, and we're affecting the programming of the particular enzyme that we're targeting rather than trying to compete against other chemicals, for example.
Okay. Yeah. And then in terms of, right now you're adopting telemedicine, specialty care medicine, which is great. And so in terms of that, like, where do you see the patient clinician relationship will go in the future?
Right. So it's an interesting question. I don't know exactly how it's going to turn out. Right now, where we're at is before telemedicine, there was, you didn't have as much access to your provider, right? So you had a year, every 6 months, every 3 months, you got your blood pressure taken once a year, twice a year, 3 times a year. Now you can connect with your provider multiple times a week. You can download the information almost every day. You, I don't know if you're, I'm sure you're familiar with continuous glucose monitors, right? So endocrinologists now are doing that, where they're interfacing with a patient's glucose monitor, and the glucose monitor is telling the endocrinologist when it's time to give the patient a call and say, hey, your glucose is out of control. You can imagine this would have never happened before that technology. Right? Apple Watch now does EKGs, right? It can track AFib. So you can imagine that these wearables are going to evolve so that we're going to get more insights into how our body functions. I always say that, we were given this body without an instruction manual, right? And the instruction manual is probably as big as a bookshelf on a library, and we're 3 books in. That's how much we know right now. Yeah. So if we can get this information, right, it's going to benefit us one way or the other. We'll find out, hey, this information isn't going to give us good outcomes, or this is really vital information, and we're going to get machine learning to help us with that, right? So because we're going to have so much information now, it's going to be hard for us to process, right? So we're going to have to use partners to help us look through all that data coming in and help us figure out what's important, what isn't important. But so I think this is the next step. It's figuring out how to get all that information, all that data, right, into the right place, and then figure out what data is important and what isn't, sifting through that data.
Okay.
Yeah.
Well, thank you very much. I think we've reached our time here, although this is such an interesting topic, and perhaps we can have you as a guest again next time.
Yeah, anytime.
There's just so much to cover, so much happening in this space, so important space. As you've said, it affects it's the #1 disorder that the United States and really the world is facing. So thank you very much for taking this time. It's a great conversation. And
a pleasure. Thank you.
Hope to see you here again next time.
This was the Future of Medicine podcast, presented by Predictiv, the first DNA-based digital twin to predict and prevent over 22,000 diseases. Learn more on www.predictivecare.com.